There it is. It's recording. Got it. Well, thank you everybody for coming. And I want to thank especially Paul and Faye for agreeing to be here tonight. I'd like to start. Well, I'll tell you why we're here tonight. The reason we're having this meeting about this subject, and we're going to have, I guess, when we're done with this subject, we're going to have the rest of the county committee regular meeting, is that on December 2nd, Paul Kendall, who is going to introduce himself in a short while, published a commentary on Vermont Digger about the need for reform in healthcare in Vermont. When I read the thing, it really registered with me as an incredibly concise summary of where we are with the success and lack of success in healthcare reform in the state. So as it would happen, I was walking down the street one day in Montpelier, and lo and behold, there was Paul and his wife. And I said, Paul, you wrote a really good piece about healthcare. And he said, well, what do you think we can do about it? He says, you're involved with the Democrats, aren't you? And I said, yeah, for the county committee. And I said, let me talk to the county committee to see if they're interested in discussing this. Well, at our January 18th meeting, that in fact we did. I had sent Paul's commentary to the committee, and we had a kind of a roundabout discussion all about it and tried to figure out how to further our discussions and our knowledge so that we can speak with some degree of knowledge about the issue. So I invited Paul, and also at that January 18th meeting, the members of the committee also said, and we'd also like to have the voice of a practitioner, quote unquote, on the ground, who is dealing with healthcare issues in Vermont, and see what they may think about not only what Paul said, but what they are thinking about in terms of the needs for healthcare reform for this state. And that's how we were able to identify Faye as a practitioner, Dr. Faye. And so I asked her if she'd participate, and she said she'd be glad to. And that's how we got to tonight. So, Paul, why don't you give us kind of a quick summary of your experience generally and of your experience on the healthcare issue?
You don't think ladies go first?
Sure, why not? Faye, it's your turn.
All right. So I'm Faye Homan. I'm a family physician in Wells River, and I've been here for 29 years, so a long time. In addition to my practice is in a federally qualified health center. If you're not acquainted with that, there are certain places across the state that are carved out as areas of need and get a designation from the federal government as an area of high need, and we're paid a little differently than other practices. And Orange County is extensively served by FQHCs. There's one based in Randolph and one based in Newbury, Bradford area, which is the one I work for. In addition to my practice, I have also been involved on the Vermont Academy of Family Physicians Board, and I'm on the Primary Care Advisory Group, which advises the Green Mountain Care Board. And so I've been steeped in some level in policy issues for a long time, and have really felt like oftentimes we're sort of shouting into the void and this is reflected, I think, in Paul's commentary, that it's really hard to know who's in charge, who has the vision for healthcare reform, who has the power to do it, who has the will to do it. And there's no easy answer there. So part of what I'd love to talk about is sort of where we go with our energy and our ideas about these things.
Thank you, Faye. Okay, Paul, now it's your turn.
Okay. I was a trustee at Gifford from 1996 to 2017. So just about a 20-year period there. During that 20 years, I held a lot of hats at Gifford, including raising money and being a board chair and so forth. But I was also very involved with the various reform efforts, starting in 2001 with the very short-lived Dartmouth-Hitchcock Alliance, which had created what they called their Council of Chairs, the chairs of all the various hospitals that were related and serviced by Dartmouth-Hitchcock. That experiment didn't last too long. It fractured along a number of lines, basically having to do with who was in control. I've also been a trustee of VAHS, the Vermont Association of Health and Hospital Services, again in the early and mid 2000s. The VAHS is mostly made up of the CEOs of the hospitals, but there are a few outside trustees appointed or elected, and I was elected twice to their board. I was very much involved with Gifford's change in its governance structure from being a community access hospital to becoming a federally qualified health center. And my last health reform effort was in 2016 as a member of the very unfortunate Accountable Care Organization Memorandum of Understanding Steering Committee, which was a hodgepodge of stakeholders that were trying to figure out how Vermont should create an ACO and cut a deal with the Center for Medicare and Medicare Service Innovation, which ultimately ended up being One Care Vermont. So I've been around for a while and have had my fingers in a number of pies, but that's the long and the short of it.
Okay, thank you, Paul. Thank you. So we'd have two very, very well-versed people in both ends of this process. One, at the formation of One Care and the healthcare reform, and then Faye's practicing during the 29 years of her practice in Vermont, seeing what has been going on. So what I'm going to do right now, very quickly, I hope, is summarize Paul's article. He makes two main points in the article. One is he perceives a conflict of interest in which between the UVM healthcare network and One Care, because One Care is under the auspices of UVM healthcare network. And therefore there is a conflict of interest as he sees it. Second of all, that there is no organized leadership within the state to deal with healthcare reform and cost containment issues. And as Paul very well puts it, he summarizes it by saying, Vermont's healthcare system resembles an orchestra without a conductor. And I think that was a very apt allegory to the perception of the fact that there's this myriad pieces of parts working, not necessarily in conjunction and not necessarily with each other. So as a result of those two conclusions, and Paul can elaborate on that now once we get more deeper into it, he suggested that there needs to be changes that needs to occur in initiatives about healthcare reform in the state. And both within government, because there's a myriad of governmental or nonprofit organizations involved in all of this right now. And because there's so many players in the healthcare delivery system a myriad of different kinds of players, different levels of organizations that are not in any way coalesced to deal with the reform efforts. So Paul, given my summary, is that about where you were going with your article?
Yes,
But
Perry.
please elaborate now, please
Well,
elaborate.
let me just back up a couple of steps, Perry, and sort of setting the table here. I think it's important that we keep in mind 3 or 4 things. First of all, that healthcare policy discussions center on 3 major topics: quality, access, and cost. They all circle around quality, access, and cost. But Vermont is very well highly ranked on both the quality and access issues, although we can always tweak it and make it better. But the big issue in Vermont has been and continues to be cost. Second point is that the evidence.
We've lost your audio, Paul. Your mic is muted.
My fault. Sorry
That's
about
okay. He's still muted.
that. Yeah. And I'm looking for him on the screen here. I don't even see him on the list.
Just hold off, Paul. Do you think he needs to do it at his end, Bob?
There we go. I got it. Oh. Everything keeps moving around. There we go. So yeah, he needs to unmute.
Okay,
I said
there, you're
unmute.
back on, Paul. Good.
All right. All right.
Oh, sir, awfully sorry. Sorry about that.
That's
That
all
was
right.
my- that was my
Not a
fault.
problem. That was on your time, not on my time, Bob.
Got it.
Okay. So aside from everybody knowing that the real issue in Vermont is cost, everybody, the evidence consistently shows that it is far cheaper to keep people out of hospitals than to pay the cost of emergency visits, surgeries, or chronic care services. All right. So if you want to deal with cost, you got to figure out how to keep people out of the hospitals. Third, I would point out that the Green Mountain Care Board was established to regulate the financial resources of Vermont's healthcare system, but it did not create that system. And One Care Vermont is essentially designed to distribute those financial resources, again, in a healthcare system that it did not create. It's very important in terms of understanding both the roles and the limitations of those 2 key players in this discussion, that they didn't create the system that they are being charged with trying to manage or distribute the finances of. And fourth, again, setting the table here, is the point that you made, Perry, in my article, that I really believe that One Care Vermont, because it is essentially a high-level specialty hospital and a teaching hospital, it has an inherent conflict of interest in terms of where its priorities are. Its priorities have to be to protect the mothership of its teaching staff and quality and its specialties, both of which are very high expense, hospital-driven rather than outpatient or primary care driven. So to where I'm coming from in all of this is to say that to make healthcare affordable in Vermont to individuals, to families, to businesses, and to the taxpayers, the financial payment system must increase its reimbursements to primary care related services and decrease them to hospital-based services. In other words, I'm saying we really have to flip it around here. Instead of primary care being the lowest paid services, we have to figure out a way to make them much more attractive and rewarded financially and supported. Second point that I make in the article is that only the governor and the legislature have the authority to change the funding priorities of Vermont's healthcare system. And only they have the power to alter the role of the Green Mountain Care Board and the focus of the current negotiations with CMMS over the future of the ACO agreement. And my last point is that our Democratic Party controlled legislature shows no signs of stepping up to these issues, as I believe that neither the Healthcare Committee in the House or in the Senate have held a single public hearing this session on their respective bills to envision and to implement the alternative of a Green Mountain Care system. So I just wanted to throw that little piece of meat out there on the table we're Democrats. I mean, come on, folks, we're Democrats. We control the legislature, but the legislature is invisible at this point, in my judgment. In any discussions of this, we know that the governor and the administration are having quiet conversations with CMMI over how to extend the ACO agreement, but we don't really know the substance of that, other than that they're talking about global budgeting, but we don't even know what that means. We also know that the CMMI wants to get greater consistency across state lines in terms of its programs, which would mean it would push Vermont to be arm wrestling with Massachusetts, Rhode Island, Connecticut, and 4 or 5 other states as to what CMMI would be willing to pay for. So those are big issues, but I don't have any sense that the governor and the administration or the legislature is going into the discussions with CMMI with a vision of what healthcare should look like in Vermont.
Paul, would you explain to us what CMMI
Yes, I'm
is?
sorry. It's the Center for Medicare and Medicaid Innovation or Services, CMMI.
And what is their charge?
Well, under the federal legislation that created the opportunity to create accountable care organizations, CMMI was given the authority to cut deals with individual states on how that would work. And so for the past 5 years, since 2017, Vermont has benefited significantly financially by having that arrangement with CMMI. That contract was to terminate at the end of 2017, but they cut a deal for 2 years to extend it so they could figure out what they want to do next.
I see. Okay. Let me turn to Faye now. Faye, you've heard Paul's excellent summary of kind of the political landscape and organisms within the mix. What does it look like from your chair?
Well, I think to start with, I will say what my colleagues would be saying is that we need many, many, many more primary care providers. And so that might be family doctors, it might be family nurse practitioners. We need just lots more of us on the ground. So recently a friend was looking for primary care in the Middlebury area. She called 7 practices, none of them were taking new patients. They wouldn't even put her on a wait list, and was even told by the federally qualified health center there that they weren't taking new patients, and that's actually against the guidance for federally qualified health center. So and one of the reasons we're having trouble at UVM with difficulty getting in with specialists, wait times to get in to see specialists, is that many of them are doing primary care work in a specialty setting. So you don't have to see a cardiologist to have your blood pressure meds adjusted. You don't have to see a dermatologist to have your moles looked at. That's all stuff that's just run of the mill, everyday, basic primary care. And there's not enough of us. And there's a lot of reasons for that. It's the lowest paid specialty in medicine. It is the teaching hospitals don't always do a very good job of messaging about what a great career family medicine is. They're very specialty oriented. So, everywhere from choosing students from med school right on through to things help with loan repayment and that sort of thing. We need lots more of us. And that's going to help access, and that's going to help get keep people out of the hospitals. I think the thing that Paul said that really resonates with me is, you know, this inherent conflict of interest. I don't think anybody's arguing that we need to dump more money into the healthcare system. We spend tons of money, way more than other countries, way more than we should be spending on healthcare, but it's not being spent in the right places. So what that means, if the ACO really had a vision for all of Vermont and how to keep all of our citizens healthy, they would be trying to get money shifted into primary care, as Paul suggested. But by default, that means that there's a little less pie for the tertiary care hospitals. And that's the thing that nobody quite wants to talk about. And I agree that the first time I ever heard about an ACO, and I mean, I remember who I was talking to and where I was sitting, it was probably 15 years ago. And he was explaining that he thought UVM would be in charge of it. And I just, even then, knowing so little about it, I said that, you know, I don't see how they could be making those decisions because of who they are. And it really will mean a shift of resources into primary care really means that there will have to be some sort of shrinkage at the tertiary care level. And that's a hard subject to bring up.
Paul, thank you, Faye.
Perry,
Go ahead.
Perry, may I
Sure,
just put a little coda on what Faye said?
sure.
When the federally qualified health centers were created, thank you, Bernie, all right? Bernie understood that primary care is not the cause célèbre of hospitals. And so no federally qualified health center can be owned by a hospital. That's why Gifford had to change its governance from being a community access hospital to becoming a federally qualified health center. Now, it's very important, I mean, because Bernie understood this nature of a conflict of interest, that hospitals do not see the world the same way that primary care sees it. And I think that's the guts of what I'm trying to get at here. And I think Faye just underscored it.
Paul, can you still hear me?
Yes.
Okay, good. I was making sure your screen wasn't frozen.
No. I'm not. Yeah. I just
Okay.
wanted to make that little historical note about who can control primary care.
Sure, sure,
Bernie says hospitals can't.
sure.
But so who did we put in charge of our health system? We put the
UVM.
largest. We put UVM. I mean, it was bizarre right from the beginning.
It's my impression, especially from the state auditor, Doug Hoffer. He's published a report, I don't know, 12 months ago, whatever, starting to question the cost, among other things, of the ACO, about how much money is being spent on it and what it's doing with it. And so it had just struck me when I was hearing that, and then I started hearing about these other issues, that it appears to me that it is in an organization, another level of bureaucracy developed to send money out. And since it is not doing the restructuring or reorganizing of the healthcare delivery system focused at primary care, that it's simply adding cost to the whole process. Does that sound right? Either of you?
Well, I'll let Faye go first. I won't jump in all the time.
I think on that one, you should jump in. It's not clear to me. The finances are not terribly clear to me. I can say from a perspective of someone in primary care, it's not clear to me what benefit the ACO has had for our day-to-day practices. So that's maybe part of the answer, but I think you should take it from there.
Okay, Paul.
Oh, okay. One of the topics of discussion I understand currently between the state and CMMI is around the old notion of global budgeting, which basically says how you divide up the money and you give pots of money to different entities. That there is nothing, I believe that under the legislation, you don't have to have an ACO to be able to manage global budgeting. You know, the Agency for Health Hospital Services, or AHS of the state, could manage that whole system by itself. So that I just think you can, your point, Perry, about another level of oversight, of administration and so forth is very well taken here. And there is the possibility of shifting it right back into the governor's wing of the administration. However, simply doing that doesn't change the vision of how Vermont's healthcare system ought to work. You still have to go back to the question of what do we want our dollars to achieve? And what is the best structure and vision for making that happen? Just changing the way that the money flows at the top doesn't get you there. It just simply says, okay, now the governor or AHS is responsible rather than one care. That doesn't change anything.
Mm-hmm. Gotcha. Now, before we go to some discussion about recommendations about moving forward, what questions do the rest of you attending this meeting might have for either Faye or Paul? Or your own comments themselves?
I knew Bernie was going to raise his hand.
And I did largely because I've heard these discussions. I think this is a very interesting discussion, and I've heard it in other states for a very long time that primary care just doesn't doesn't share the spotlight, let's say, and as it should. But are there other states that I think Paul, you had said that Vermont has done very well from CMMI, and do you see other states that have addressed this problem of primary care better than Vermont has?
Bernie, I can't answer that because I don't know other states.
Mm-hmm.
I can't go there. Sorry.
Well, I can say that our neighbor, New Hampshire, in the long run, I was in the legislature there for 16 years, for quite a while. Probably 8 years ago, I retired, but it was every year that was the discussion we had, and I'm not quite sure where they stand either now.
Faye, were you going to say something?
I could just add one thing about, what other states have gotten it right. I think it's almost not an issue of our states. It's an issue of our entire country's sort of focus on specialty care and high-tech care and hospital care. And compared to other countries, we are very lopsided with how many the ratio of primary care to specialty care and the amount of money spent in primary care to specialty care. And in these other countries, and that's true, very much true of Canada, also most of Western Europe, and even many of the sort of more developing nations, they really have a focus on primary care. And because of that, they have less, that they spend way less on their healthcare. So part of it is a USA healthcare problem. There are some states that have worked hard on trying to get more money into primary care. I know Rhode Island and Maryland have had some programs that have had some success, and there's publications about that. I don't know the nuts and bolts about them, but one of the strategies has been just to tell the insurers, you have to spend X percent of money in primary care, and let them figure out how to make that work in the state. And I understand that has been reasonably successful in Rhode Island and Maryland. And I think Oregon has something going on in that score too.
Okay. So, any other questions or comments by anybody in the group?
Kelsey's got her hand up.
Go ahead, Kelsey.
I had a question. So I'm putting on my not political hat, but as someone who I'm actually on the board of where Faye works, and I have taught a diabetes prevention program through Gifford Hospital now for, well, I've lost track of how many times I've done that, plus being a yoga teacher for a decade. And I'm curious about both of the speakers, and hi Faye and Chip, nice to see you both. Of your thoughts about, bringing others into this conversation about healthcare in general, because often, the United States is treated as disease management rather than health care. I see people every day in my yoga practice who are coming to me with physical ailments that other things have not helped, but they need to work on their bodies in various ways. So I'm just curious about bringing other voices into that conversation and what your thoughts are on that.
I think there's a increasing recognition in healthcare in general about, well, one of the buzzwords, but it's a very true one, is the social determinants of health, and all of socioeconomics, where you come from, what kind of stresses you have in your life affecting your health. And I think there is a move federally to sort of encompass some of those issues into healthcare more than has been in the past. And actually, for federally qualified health centers, that's a fairly significant part of what we do with a lot of behavioral health. And as you know, Kelsey, at ours, we have counselors in the schools. We have Tai Chi classes for people with substance abuse and back pain. And so I think that that's happening. In terms of healthcare reform in Vermont, I can say that there's, I think there are a lot of good voices for on the boards that I've served on, or mostly PCAG, I guess I would have to say, for groups that really want to keep a focus on that more global definition of health. I think we're moving that direction.
I guess my question of the group, Perry, would be that I'm going to assume that we're essentially dealing with a political problem. And the political problem is that all the money and all of the what money can mean in terms of politics is with the hospitals. I mean, they're the major employers in town. They have tremendous leverage over a wide swath of elected officials and businesses. So looking at it as a political problem, and here we are, a political organization, how do we develop the conversation in a way that it influences our own political leadership? I mean, from our own political leadership, if we were to go and ask them, how can we build momentum behind doing the right thing here now, of trying to envision what our system ought to look like? What do you, as a political leader, need to hear, and from whom, and for how many? I mean, it's a political campaign. That's, long and the short of it, from my perspective. Because if you just go out and ask everybody on the street, or you just go out and you ask all the wonderful people who are actually providing various kinds of services, whether they be home healthcare nurses, or any one of the designated agencies, in the state, mental health and so forth. They've all got ideas. Of course, they all are needing more funds, and we're going to seek more funds for themselves too. But the real issue is what do our assuming that our political leadership also believes that we should be making this transition away from hospitals and more towards primary care, what do they need? That would be my question to this group.
I think
Hi,
it
my
goes,
name's-
go ahead.
Oh, hi, my name's Sabra, and I guess I haven't heard the issue of, or the problem of insurance companies and how much they are getting. And when you ask what does it take, it took the Workers Center with the campaign for healthcare as a human right, having daily people sitting in on every single committee that was taking on healthcare to try to get Vermont signed on under Shumlin to have single payer healthcare. That's what it takes. And even then, it didn't happen. So I don't know. I don't see anything going on with what's now Rights and Democracy, what sort of morphed into Rights and Democracy, having that kind of level of commitment in the State House. And I think that's what it is going to take if that would even work.
All right, thanks, Saber. Carl, you have your hand up? I think. you do.
Yeah, yeah. Can you hear me?
Yeah, we can.
Yeah, I kind of almost hate to say this, but I think now and for a long time, the chairs of the relevant committees in the legislature have all been from Chittenden County. And that does not help when it comes to reining in UVM. And how that gets changed, I don't know how we do it, but I think until that happens, we're going to continue to see UVM sort of taking, cherry picking patients, taking most of the specialized patients in the state, and I think that primary care is going to suffer for all the rest of us until that changes. And I may be way off base there, but I think that that's the way. That's sort of what I see from where I sit. And I see, I can't at all disagree with anything that Paul and Faye have said. And I think there's a very similar situation going on in mental health right now as well, although I think it's not anywhere near as well funded. But we've also got, the emphasis these days is more on crisis than on prevention. And how we fix that, I think I don't know. I wish I had answers to all these. I'm willing to work on things if people have got answers out there that they want to share with me.
Okay, I have hands up from Chip and then from Melinda. Go ahead, Chip.
Thanks. So I think Carl is not wrong that the fact that the chairs are from Chittenden County has at least some effect on the willingness to confront the hospital when that is the right thing to do. I do think that to Paul's question, that what it will take is a cogent proposal that comes to the legislature about the direction that the state needs to take by working through the legislature. One such proposal is a universal primary care system, which there's a bill in there, has been in the past, and there's a bill there again now. It's not getting any real attention in this session. I don't know whether it will in the next session or not. I guess what I would ask Paul is that it seems like there is an opportunity that if we are going to make some changes, as he nicely put it in his article, that we need a conductor, we need someone to come forward with a plan, or some group of people to come forward with a plan. And it seems like this moment where we're renegotiating the all payer waiver for the ACO could be a moment where there's potential for some real change if that kind of a proposal can come forward. And so I guess I would ask Paul 2 questions. One, does that seem like an opportunity to you, and how might we take advantage of it? And secondly, as again, I think you said in your article, that the ACO, the existence of an ACO, this seems like there are some potentially good things about it. It essentially is a way to pool all or most of the healthcare money that comes into the state and to distribute it. And the way, and there's the ability at that moment to determine how it gets distributed, that to funnel more of it towards primary care, or certain parts of the healthcare system that we think really need greater resources. So I guess I would ask, Paul, do you think there's a use for the ACO that's different than it is now? And maybe lastly, I've never seen the ACO as sort of the leader of healthcare reform, although they seem to, in some instances, take that as part of their charge. And so how do you feel about whether they should be playing that role?
Well, thank you. I think it's Vermont, One Care Vermont has backed itself into a corner because it has precisely advertised itself as being the leader of healthcare reform, and that it can do it, when in fact it can't, because all it is a distributor of funds.
Mhm.
All right. And the issue is, and whether it's the Green Mountain Care Board who says it, or it's the legislature saying it to the Green Mountain Care Board as it tries to manage One Care, it simply says, you know, you've got to put a greater percentage of your money into primary care. I mean, it comes down to that. Now, the window of opportunity, I think, is this negotiation currently between the administration and CMMI. But the legislature's leadership is strangely silent on this issue. I think, quite frankly, that the governor has shown an interest finally in healthcare reform. He didn't during his first couple of terms, but now with his recent appointments to the Green Mountain Care Board, he's beginning to shake some things up. So I think there is an opportunity if the leadership of the legislature were to go to the governor and say, you know, this is the time. We want to be with you. We want to come out of this united, and it's not going to be a Democratic or a Republican kind of victory. It's going to be a Vermont victory. Okay, and Vermont is going to be a victor if we can start shifting the allocation of resources, and we want CMMI, the deal with CMMI, not to tie our hands, but if possible, to even further enable us to do that. So yes, I think there's a window of opportunity here, but I'm still looking for the leadership to take advantage of that window of opportunity.
Linda.
Yeah. In our neck of the woods, a fair amount of the specialty medical care is provided by Hitchcock, which is in New Hampshire. And I have never quite been able to figure out how One Care and our whole process deals with out-of-state hospital and reimbursement, and what role that plays. I'm sure the same thing applies on the western side of the state, where they may be going to Albany or wherever. So Can somebody help me understand how this system accommodates crossing state lines for care of any kind, really?
Good
Do
question.
we know?
Well, I will take and Faye, you may be able to help on this. I have a very limited understanding of it, but it's essentially in two parts. First part is that Dartmouth Hitchcock was and remains to be a primary founder of One Care Vermont. It was a deal cut between University of Vermont Health Network and Dartmouth Hitchcock to create One Care Vermont. All right, they were partners, and each one had a veto over whatever was going to come down the pike. All right, and even though there's a large board of all sorts of players now on the one represented on the One Care board, Dartmouth Hitchcock is basically pulled out because it wasn't meeting its needs. So I'm sure there's some legal and lots of technical answers to how the funds flow and who gets to charge how much and so forth, which I can't answer. But Dartmouth Hitchcock was initially a part of the One Care leadership and control, but it has basically relinquished that and turned it over to
UVM.
University of Vermont Health Network.
Faye, do you see anything at your level about this? Mic's off. Mic's off. There we go.
Yeah. No, I think, I guess what I'd say is I'm not aware of any problems with how the system works, meaning that our patients certainly, so my own FQHC is not a member of the ACO. There's a whole backstory to that, but many of them in the state, most of them are, and I've not heard any stories about people not being able to get the care they need at Dartmouth. So whatever it is worked out in the paperwork and the details.
Okay. Okay. So I think what I understand from the discussion tonight is the issue of the allocation and restructuring and possibly the restructuring of the healthcare environment, at least to focus primarily on primary care. And that we have a system that doesn't do that. I noticed in Paul's article, when he talked about the healthcare provision community, here's what he mentioned. Community access hospitals, regional hospitals, medical center, rural health clinics, federally qualified health centers, independent mental health, home health, housing, aging, and visiting nurse organizations, as well as private medical practitioners, optometrists, and dentists. That, I think, is the playing field where healthcare gets delivered in a variety of ways. If the from your comments tonight are that there is a need for a strong voice from the democratically controlled legislature to emphasize the extreme need for this restructuring of the system, concurrent with the process of the negotiations going on between the governor's office and CMMI, then it would seem from a county's committee perspective, if we agree that's the case, that we might need to communicate this to the state committee to get the ball rolling. And then the state committee would have to decide that a information campaign and a political campaign needs to be focused on the legislators in place now in the legislature. Is that Does that seem like where we as a body could put our energy in? I'm asking everybody in the room now.
I would say yes. We could bring up at our meeting to have just what you said, bring it to the state committee and have them vote on it and then start going out from there.
So I'll jump in with a little bit different perspective. I mean, I think having the state committee, having Democrats around the state, talking about the need for reform is helpful. I think it's much better if there is something to get behind, if there's an actual, a plan for where we're going and how we're going to get there to get behind, to support, whether it's whether we have to, convince the administration or convince more of the legislature. And in that situation, I think it would be tremendously helpful to have the state party and the counties, lined up behind something. But I go back to what Paul was talking about earlier, and I asked about, which is, so the legislature could come up with a plan. And individual legislators have worked on this, and plans have been put forward. As I say, there's that bill about universal primary care in there that is a vision of one way to go, but it's not getting any traction at the moment. And unless there are some proposals being developed right now, I don't think the legislature is going to on its own come up with something in time for the renegotiation with CMMI. I think what needs to happen is that a proposal that seems workable, that aims to keep costs from going higher than they already are, or keep the increase in costs at the level it is, or even reduce the increase in costs, that will also provide the kind of quality and answer the questions about access and stuff that the legislature is well aware of. If that plan, if some proposal about what we do in the renegotiation was to come forward, then I believe the legislature could get behind it, and that the work of the Democratic State Committee would be very helpful in supporting that. But I guess just saying we need to, the legislature is well aware of the need for reform, the need to keep costs down. That I think need something to rally behind.
Well, let me just make a suggestion, because I think that comment is right on. There is a bill, it's S-84, okay, which calls for increasing the spending for primary care of Medicare by 1% a year to 15%, okay? It focuses on saying at least we can start with Medicare, and let's make sure that we gradually increase the amount of money or percentage that's being spent on primary care. There's a little bit of a weasel word in there, because when it comes to Medicaid, which of course is a Vermont money as well as federal money, they say it's only to the extent that it's practical would we do the same thing with Medicaid. But my point is that at least there is a bill upon which there have been no hearings, that is in front of the Senate Health Welfare Committee, S-84, that begins to take a stab at saying, let's at least start flowing more money in the right direction, even though we may not have figured out what the total vision of universal access might be, or what Green Mountain Care might look like. At least we could start with flowing some money in the right direction. That's
Okay.
before the Senate right now.
Also,
But-
Paul, let me ask, Paul, are you conversant with the primary care bill that Chip talked about?
No,
Okay, all right.
unless he's talking about the one that's currently called the Green Mountain Care, which there is a bill, H-156 in the House, and in the Senate, the companion bill is Senate S-74. Those, I believe, are the only ones that I'm aware of that deal essentially with what Chip was talking about, but it may not be the same thing.
Sure. So the bills that I just heard alluded to were S-74 and H-156, did you say?
Correct.
As well as H-84, or is it S-84?
It was S-84, which was just
S-84.
a funding piece. Yeah.
Okay.
The other two are much more global and long range.
Okay, okay.
So the universal primary care one that I was referring to, it may be those, but it's sponsored by Brian Chena in the House, and it has 60 co-signers. So again, I go back to the legislature knows about the issue. There are proposals, but there has to be one that gets some steam.
Yeah.
That's probably a conversation that happens in the speakers in the pro tem's office before it really happens in the committees. I will just say, I just can't resist. So that bill about increasing this primary care spend rate, I had the exact same bill in there when I was in the legislature. Mine actually required us to get to a certain level of primary care spending by a certain date. Again, a great idea. I think my own comment on my bill is that you do want to have an idea of how you're going to spend that money if you increase the spending in primary care, but it was an attempt to do the same thing. And these bills are there over the years. They keep coming in, and again, the legislature is well aware that we need to address the problem, but there hasn't been a vehicle that really has been able to galvanize enough people to make progress.
But who would you think creates that vehicle? How do you get that vehicle created, Chip? Is it the legislature who creates it? Is it the administration that creates it? Who are the wise longbeards, the six wise women, wise men who get together and say, this is what we need?
Yeah, I think that's an excellent question. And I think, and I know, so the legislature is capable of doing it. Whether there are people working on it now, I don't know. Carl might be able to weigh in on that. The administration certainly could do it. But again, and so what I come down to is I think a group outside of those two that recognizes the opportunity, the moment, and is willing to put in the work, and I know that there are some people who are, trying to get some ideas together. And I think you can see that in other commentaries in Digger like yours, that there are people out there who are thinking about this. And I think there is, I guess I'm hopeful that there's some work being done along those lines, but it's an excellent question. And I think until we answer it, we're all going to be, having meetings like this where we're uncertain where we're going or how to get there.
Well, my guess is that meetings like this, and I will call on you, Carl. I just want to say that meetings like this, in order to grow the plants, we have to plant the seeds. And the more people become more conversant on the issues and the dilemmas, I think, who have some degree of access to the political system, the better chance we have for those issues to grow. Carl, what were you going to say?
Well, I was just gonna try and answer Chip's question about, who those people are, and I think they're the chairs. And getting in front of the chairs of House Healthcare and getting in front of the chair of House Human Services, I think that's and Senate Health and Welfare, that's the place to do that. If the chairs aren't on board, then there's not much chance of it moving unless it's coming from the Speaker of the Pro Tem's office. And both the House chairs of the relevant committees are new. They've both been on those committees for quite some time, but they're both new to being chairs. I mean, that's Chip, you'd be amazed at how things are not moving anything like they did in 2019. Things are a lot slower. We've got a lot of new chairs. And a lot of new members too. And I know that when that happens, committees tend to be looking at crises rather than sort of long-term planning. But there's always next year, right? And a lot of the priorities that the legislature is trying to get across the finish line now, and for this session is the focus, but soon it will be time to start thinking about what happens next session. And I think that creates an opportunity for this.
I have to take a break and I'll be right back.
So are there any other questions while Perry's off?
Jean, you have your hand up?
Who is that?
Yeah, it's Dr. Homan, is that right? Faye Homan?
There.
Can you hear me?
Yes, she hears you. I see her.
I hear you. Sorry, I didn't, did you ask a question? I hear you now.
Go ahead, Jean.
Jean is on mute.
Right.
Jean, you're mute. There you go.
Give me? Yes, I was pleased Dr. Homan, if I can abbreviate, pointed out that other countries have success where we don't seem to even try. I had two little boys, 9 and 7, go with me to France for a couple of years, and it was absolutely marvelous. I had access to healthcare. I had the carnet de santé, their records. If I failed to do their inoculations, I got a little postcard that probably everybody in the building had a chance to see. But yeah, I mean, other countries do it. We can do it. We can do it here in Vermont.
And they truly are primary care based. In Canada, even pediatricians are considered specialists. So everyone has a family physician, and even seeing a pediatrician would be if there was something complicated that they needed to see a specialist for. So we just need, I mean, that's a system that needs to be built, and that's what works in the countries that have much, much lower costs of healthcare. But I have a statistic, and it's not right in my head. I wish it were. A few years ago, there was a report about the number of physicians who had come into the state in the previous some number of years. And what I recall was that there had been something like something in the teens for new primary care docs and 640 new specialists. Like
Oh,
we're just still building the system that is specialist oriented, and that's going to generate just more cost. And it's hard to turn that ship, because even if you started today with training new primary care docs, it's 10 years before they're out in practice.
Yeah.
And
Oh.
mostly towards Faye, but going a little bit back onto what I was saying earlier, looking at cost and preventative medicine. I know a lot of European countries have a little bit more expansive view on what they consider medicine and looking at some of those preventatives. So I know even at the FQHC that you work at, Faye, which I'm very familiar with, looking at how to expand things like the pain clinics, people who are dealing with chronic pain, and finding ways to support them that is not based on opioids, which
Right.
I will not go on a rampage, but working on an organization that deals with substance misuse. Vermont has been hit extremely hard by substance problems, but looking at how to save costs that way from preventative medicines. For instance, it's much easier to prevent diabetes than to treat it once it's already begun.
Right. And that's very much the purview of what most people consider primary care. And yet the resources, the way we pay for healthcare is to value procedures and value surgeries and value interventions. And that the kind of work that I know you do in your work, Kelsey, and I certainly do in mine, where you're just sitting and talking with people and hoping to move their behaviors a little bit, inch along with nutrition, with physical activity, that's not really valued in terms of how you get reimbursed in medicine. But if I want to biopsy somebody's mole, that's where the money is doing the procedures. So yeah, the structure of the whole system needs work.
Gene,
So
go ahead.
can I just jump in for a second
ahead,
on the
Bob.
subject?
Yep.
So having recently had a heart attack and being diagnosed with diabetes, when I was in cardio rehab, right at the very beginning, I realized that of the 8 people in the room, I was the youngest, and 7 of us had been recently diagnosed with type 2 diabetes, and all of us obviously had a heart attack. And it was interesting to hear when this all happened. And it was after people had COVID. Each of them had COVID all of us had COVID in the room. Actually, 7 of us ended up getting diagnosed with type 2 diabetes within a year after it. So that makes me nervous because, it costs about $1,100 a month for Victoza that you shoot into your stomach every day. I mean, I've got insurance, but still somebody's making a killing on this. And now they're finding the tie between the diabetes and heart disease causing heart attacks. So, because there was no explanation why I had a heart attack. And there were 3 other people in the room who it was like, there was no actual reason why they could point to. So anyway, I'm a little nervous about COVID and the fact that, there are a lot of people that have been affected by it and have long COVID as a result of that. I don't think we're done with it yet,
Oh, no.
It's scary.
Thanks, Bob. Gene, what were you going to say?
I'm wondering if anybody remembered an article that I hope I pronounced it properly. Atul Gawande wrote for the New Yorker several years back, where there was a comparison between 2 towns in Texas with similar. Thank you, Bob. With similar populations, similar facilities, etc. One had very successful results, and the other very mediocre. And it turns out that there were facilities such as what Kelsey's just presented, where you could go, you were reminded of your appointments, you were encouraged to take early action, as opposed to some of the experience that we have here in Vermont, where you say there's something really wrong with my back. How many months do I wait to have an MRI? Don't get out the scalpel until we've chatted.
Yeah, I was just coming up on a year of having a torn rotator cuff before I finally got relief. So I've literally been in pain for the last year, waiting for the next appointment, because you have to go through the process. You know, you have to go to physical therapy before you can get an x-ray. So you do the physical therapy for 8 weeks, then you can get an x-ray. The x-ray doesn't show anything. So then they have to schedule an MRI. MRI, you have to wait a month or two to get an MRI. And then you know, it's just it's a nightmare. And I just say take the insurance companies out of the equation, and I think things would be a lot better.
Thanks, Barry.
Barry,
Yep.
since we're telling personal stories here, let me just tell you my recent experience. Yeah, I broke my leg 3 weeks ago and ended up at the emergency room in Gifford. And they had me overnight because I was in great pain. I couldn't walk. And the physician who was on duty spent 2 hours from about, I say, 1 a.m. to 3 a.m. calling every single hospital in Vermont and Dartmouth Hitchcock if they could transfer me. And every single hospital turned her down.
Wow.
There was no place for me to go. So I begged them to let me stay there until about 7 a.m. so my husband could put me in the car and take me to an emergency room, because if you go to an emergency room, they have to accept you. So we drove to Copley and they accepted me, and I got an appointment with an orthopedic surgeon 2 weeks later.
So what are you supposed to do with a broken leg?
For 2 weeks. And that was just the appointment to evaluate me. Who knows when he would have operated on me. Thank goodness, I'm making a very long story short. On Monday morning, it was a Friday. So I was injured on a Thursday. This was happening on a Friday. Nothing happens in hospitals on Saturdays and Sundays. I couldn't get a hold of my primary care physician until Monday morning. Called her immediately. It's Dr. Coombs at Gifford. And while I was on the phone with her, I got a call from Gifford telling me that their traveling orthopedic doctor was there and could I meet with him at 1:15 that afternoon.
Wow.
Because they don't have a surgeon there. Until I guess the end of the summer, someone's coming in. That is the healthcare system in Vermont. I was lucky.
The
Yeah, me
issues,
too.
the issues with not being able to get hospital beds or not being able to be transferred to a hospital, or that this is a post-COVID thing that has much to do with staffing.
Yep.
Yes.
It's absolutely extraordinary right now. We have at our little local hospital people sitting in beds who have heart attacks who cannot get transferred to tertiary care hospitals where they really need to be. I had that with a 44-year-old woman, a patient of mine with a heart attack recently, and she stayed in our hospital for 4 days with an acute heart attack, waiting for some hospital in all of New England to take her. The same on the flip side of that, we have a hospital full of people who belong in nursing homes, and the nursing homes don't have staff and can't take them. So our little community hospital has people that are too sick to be there and too well to be there. And that's not anything we're going to address by, I mean, I think supporting primary care would help this somewhat. I think you'd have fewer people in the hospital, but staffing issues are just really critical to making this system work again. It was never like this pre-COVID. So I have hope that it may settle down at some point, but it's quite a mess right now.
Hey, I have a question. This is so similar to the process that the Workers Center used in their campaign, the Healthcare is a Human Right campaign. And I'm just curious of the people here, how many were, participated in that, in the making testimony or hearing the testimonies? Did anybody?
When was this?
Well, it was when Peter Shumlin had the opportunity to create single payer healthcare.
I recorded all of that. I have videos of the whole thing.
Yeah, but I'm asking if anybody here participated or heard the testimonies.
Sabre, I believe you and I were the only ones on the day that we gave testimony.
Okay, I mean, because it was a brilliant campaign and Paul sort of, I mean, I don't know if he was trying to allude to this or not, but he said, you know, what do we think? Are there 6 wise men or women that are going to lead this charge? And I don't think there are. And I think that campaign was brilliant. It was weird for me because my partner is English and we have experienced, Jean, like what you discussed with my mother-in-law's, he was American, but he died of cancer, with home visits, but and then it said he wanted to pay it and they wouldn't even take any money. But the process, so what I wanted to say is that when I was first approached to do a little 1 minute, what they did was they got everybody to just use a cell phone for 2 minutes and talk about these little testimonies like Bob has just done, like Billy has just done. And they had many, many, many of these that they could go and show people, like, look, this person got discharged from a psychiatric hospital and committed suicide because they couldn't afford the insurance, et cetera. And it's an extremely powerful process. And I guess I would say there aren't 6 men or women, and that somehow we need to go back to that and, you know, stage what they did stage and try again. Because I think that the thing that hasn't, Bob alluded to it, but you know, the insurance company piece is huge. And one thing that I wanted to share is that our pediatrician in this whole campaign testified with, actually Sarah Copeland was there, that how many of her colleagues just gave up even wanting to be doctors because of having to deal with insurance and having to fight to get the services that they, as doctors, knew that that their patients deserved, and then they would get denied, and also just gobbling up their time. Anyway, I'm rambling on, but I just wanted to say that I think that we need to go back to that campaign. And we isn't the Democratic Party. I don't know what's happening with the Workers' Center anymore, but somebody should do this.
Thank you, Sandra. Well, this isn't a fix-it meeting. This is an information meeting. And Paul and Faye have given us tremendous amount of very valuable information about this. I think that we're going to have to figure out what we need to figure out at some point here. And decide whether the county committee wants to do something or not. And so I think I have to leave it at that point. So again, Paul, thank you very, very much. And Faye, thank you very, very much for giving us all this information and all this tremendous knowledge we have of what you've given to us. And we'll let you know what cooks.
Well, thank you for the
parting.
opportunity.
Do you have any parting comments, either of you?
No, I just thank you for the opportunity to share a little bit more of where my head is at on this. And, you know, I trust the wise heads of your group to figure out what the next appropriate step should be. So thank you.
Thanks, Paul and Faye.
You're welcome. Appreciate the opportunity, and would be happy to talk to anyone at any time more if the boots on the ground perspective is helpful. So
Okay.
thanks very much for inviting.
Thank you so much.
Bye-bye.
Thank you so much.
Okay, I'll hand it over to you, Sherry.
Okay. We're going to move on to our business meeting. But before that,
Make it quickly.
well, there's only one thing on the docket here. Just let me get back to gallery. I just wanted to introduce Bob. Oh, well, he sort of introduced himself, but I forgot him at the beginning. And he has helped us a number of times, and I just wanted to say thank you for coming on to help us. Oh, and Linda reminded everybody about our Act Blue donations, pass the hat around, which we do when we're in person. So if anyone wants to do that, that's in the chat. And then I will, let's see, start the business meeting.
I'm going to sneak out. Thank you.
Okay, thank you.
Thank you, Bob.
You bet. You bet. Glad to help.
So we have 9.
I am too. I need to get a big document done for tomorrow.
Okay,
Thank you.
so let's see, we have,
Whoops.
we don't have anything. We have 8 people and but we don't have anything. Well, we do. We're going to vote on the minutes and the treasurer's report. So first is I sent out the minutes from January's meeting. Did everybody get a copy of those?
Yes,
Okay, is there any changes or additions to the minutes? Seeing none, then we will have a vote. All, does anyone, so
I
someone,
move that they be accepted,
thank
Sherry.
you. And second, okay, we have a second. All in favor of accepting the January 19 minutes written by Justin Will, say aye.
Aye.
Aye. Anyone opposed?
Abstention.
Abstention
Wasn't there.
one here,
I
okay,
abstain, wasn't there.
okay. So that passes. Now, treasurer's report from Linda, please.
Okay, then, let's see, since our last meeting, I sent Sherry a reimbursement check for $149.90. That's the cost of 1 year's worth of Zoom account for our meetings. Those of you may remember that we had an ongoing thing with Windsor County, which I'm not going to go through the whole thing again because life is short. But long story short, we had sent them $175 check, which was not cashed. And I finally was able to connect constructively with the treasurer from Windsor County. And she said she couldn't find the check. And we agreed that she would tear it up if she found it. I sent her a second check and she cashed it. So that's off our books, I'm happy to say. Our last meeting, we passed the hat. We got $35 from the hat passing. For those of you who don't know, the link is in the chat. Just click on that and you can make a donation. It keeps us going, so it's very nice. At any rate, we got $35 and we paid Act Blue $1.39 for processing it. Then we received $266 from the Vermont Democratic Party, which is the kickback for the third and fourth quarters that we get for the, geez, what are we calling it now, Billy? Billy's still here.
No,
No, well, whatever we're calling the continuing, ongoing.
Dem Club.
Dem Club, thank you very much. So we get a kickback for our county's contributions to the Dem Club. And that came to $266 for the last 2 quarters. So that was very nice. We put that in the bank. We collected $17 in cash from the legislative breakfast. I do have a question. We sent Mark McDonald $300 for his campaign shortly before he had his healthcare event, and it's never been cashed. So that's still sort of sitting outstanding on our books, and I'm not quite sure what we want to do about that. Our current balance without, let me try this again. Considering we still have the $300 in our account, our current balance is $1,055.03. If Mark cashes the check, our balance is $755.03. So if anybody has a thought about what we should do other than I and or Jean to bug Mark to see if he can find that check and cash it. Thoughts, Jean?
I'm happy to give him an ultimatum in person. I haven't been to the legislature for a while. I'll drop by at breakfast. I will see to it.
Thank you, much appreciated. I
He
just,
can do either,
mean-
but he must do something.
he
Right.
must do something, and it is on a campaign finance report that we donated $300 to his campaign. So if he's not going to cash it, I'm going to have to figure out how to report getting the money back, or
And I
the
don't
fact
want
that
you to
the
do
money
that.
didn't
And
go.
I apologize. Well, on his
No, it's
behalf,
not
I
yours.
apologize at this hour that everyone has to deal with this, but he was a bit distracted this year.
Yeah, Can
I am aware.
may I ask,
So, yeah.
That, Gene, how is Mark doing? I've been away, so I knew of his event, and how's he doing now?
He's doing very well, goes for a walk every morning. I don't know, a couple miles. He's obviously very busy because he doesn't give his sister any time, but as I say, I'll show up right at the State House.
So he went back. He's in the State House. And
Yeah,
he's doing everything he
absolutely
can.
fine.
I hope not, picking up bales of hay, but
No, quite the contrary. That's exactly what he's doing.
oh, really? Well, that means he's recovered well.
And
He
I can
doesn't
tell
turn
you,
purple from it the way he does with some legislation. So, but I speak out of turn, and Linda has the mic.
that's right.
Questions? Perry?
Well, no, I just wanted to tell Bernie that at the February 20th legislative breakfast, not only was he participatory and strong, but in order to make a really important point, he actually stood up and lectured the group. So he did not appear without energy.
Great.
Thank you, Perry.
So I just, since Justin had to leave, I'm not quite sure what's happening with the minutes.
Oh,
But
he
I
asked
have-
me to keep recording, and then he would do
Ah,
minutes from the
Okay,
recording.
I will also send him a written treasurer's report. So he
Okay,
can refer to that,
okay.
which
So
is pretty
we
much
should-
everything I just said.
We should vote on accepting the report as either 1055.03 or 75.03.
755.03
Okay,
is officially the number, even though
number.
the check has not yet been cashed.
okay. All in favor of accepting, oh, we need a movement first.
Motion.
Come on.
Motion.
Getting late.
Okay. All in favor of accepting the treasurer's report, say aye.
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 Okay, any abstain? All right, on to the only business that we have, which is a report from Perry and Jean on the legislators' breakfast. And then we
Here
can
it
say
is,
goodnight.
real fast.
Okay,
We got a really good turnout of legislators. We had 9 legislators there. Or was it 12?
9.
9,
I
right,
gotcha.
including one Republican, which included Gina Galfetti, who I really appreciated her coming, and she was participative and very engaging. And we had a good back and forth, an energetic meeting, of course. At the time, the library issue about the state, about Vermont State University and Vermont Tech got a lot of airplay because there were folks there from Vermont Tech about the hot issue that's in the media right now between the world and the administration of the university. The legislators did a very good job of reviewing the activity that and the committees they're involved in. They were very concise, and the meeting was very well discussed about all the issues. And that's what my take on it was. And I tried as best as I could as the moderator to make sure we had order in who could speak. Let me put it that way.
You did a good job.
Let me just add that there were 3 legislators who did not appear, and in the words of the Herald of Randolph, that's just what they said, failed to appear.
That's right.
The Randolph Herald did an excellent review of the meeting on I think it was Thursday, the 23rd, it came out, and I cribbed notes from it because it really showed how seriously they took it, that it was a very good opportunity. And I think anyone reading that article would say, oh, maybe next time I'll go.
Yeah.
Yeah.
Tim did a good job.
Yeah, it was a good article.
So that's it.
Okay. Any questions from anybody?
What should I eat for dinner?
Time to dinner. Yeah.
I can smell dinner cooking in our house.
Hey, thanks, everybody. I thought it was really
Motion to adjourn.
Motion to
Move we
adjourn,
adjourn.
seconded.
second. All in favor?
Aye.
Bye. Good to see
Good
you
night.
all.
Thank you.
Thanks,
everybody.
guys.
Bye-bye.
Bernie.
Bye.